Hello everyone. Welcome to our channel, and in this video we are gonna talk about congestive heart failure. What is heart failure? Heart failure is the inability of the heart to pump sufficient blood to meet the needs of the tissues for oxygen and nutrients. In the past, heart failure was often referred to as congestive heart failure or CHF, because many patients experience pulmonary or peripheral congestion. Currently, heart failure is recognized as a clinical syndrome characterized by signs and symptoms of fluid overload or of inadequate tissue perfusion. The term heart failure indicates myocardial disease in which there is a problem with contraction of the heart, systolic dysfunction, or filling of the heart, diastolic dysfunction, that may or may not cause pulmonary or systemic congestion. First, let's have a brief anatomy review of the heart.
The heart is made up of 4 chambers, 2 upper chambers known as the left atrium and right atrium, and 2 lower chambers called the left and right ventricles. It is also made up of 4 valves, the tricuspid, pulmonary, mitral and aortic valves. The right atrium receives non-oxygenated blood from the body's largest veins, superior vena cava and inferior vena cava, and pumps it through the tricuspid valve to the right ventricle. The right ventricle pumps the blood through the pulmonary valve to the lungs, where it becomes oxygenated. The left atrium receives oxygenated blood from the lungs and pumps it through the mitral valve to the left ventricle. The left ventricle pumps oxygen-rich blood through the aortic valve to the aorta and the rest of the body. Cardiac hemodynamics. The basic function of the heart is to pump blood. The heart's ability to pump is measured by cardiac output, the amount of blood pumped per minute. Cardiac output is determined by measuring the heart rate and multiplying it by the stroke volume, the amount of blood pumped out of the ventricle with each contraction. Cardiac output usually is calculated using the equation cardiac output is equal to heart rate times stroke volume. The heart rate is primarily controlled by the autonomic nervous system. When stroke volume decreases, the nervous system is stimulated to increase heart rate and thereby maintain adequate cardiac output. Stroke volume depends on 3 factors: preload, afterload, and contractility. Precise measurement of these factors requires hemodynamic monitoring. Preload is the amount of blood presented to the ventricle just before systole. It increases pressure in the ventricle, which stretches the ventricular wall. Afterload refers to the amount of resistance to the ejection of blood from the ventricle. To eject blood, the ventricle must overcome the resistance caused by tension in the aorta and systemic vessels. And contractility, the force of contraction, is related to the status of the myocardium. Now we are gonna show you a simple explanation of the pathophysiology of heart failure. Damage to cardiac myocytes and extracellular matrix leads to changes in the size, shape, and function of the heart and cardiac wall stress. These changes lead to systemic neurohormonal imbalance. This may lead to fibrosis, apoptosis, hypertension, hypertrophy, cellular and molecular alterations, myotoxicity. This will lead to progressive remodeling and worsening of left ventricle function and will lead to morbidity and mortality, arrhythmias, pump failure. Another result is hemodynamic alterations, salt and water retention, and this will lead to heart failure symptoms, dyspnea, edema, fatigue. Now, let's talk about the clinical manifestation of heart failure. Assessing for heart failure. Be alert for the following signs and symptoms: general, fatigue, decreased activity tolerance, dependent edema, weight gain, cardiovascular, third heart sound, apical impulse enlarged with left lateral displacement, pallor and cyanosis, jugular venous distension, respiratory, dyspnea on exertion, pulmonary crackles that do not clear with cough, orthopnea, paroxysmal nocturnal dyspnea, and cough on exertion or when supine, cerebrovascular, unexplained confusion or altered mental status, and lightheadedness, renal, oliguria and decreased frequency during the day, and nocturia, gastrointestinal, anorexia and nausea, enlarged liver, ascites, and hepatojugular reflux.
Now let's talk about assessment and diagnostic findings of heart failure.
Assessment of ventricular function is an essential part of the initial diagnostic workup. An echocardiogram is usually performed to confirm the diagnosis of HF, identify the underlying cause, and determine the HF, which helps identify the type and severity of HF. This information may also be obtained non-invasively by radionuclide ventriculography or invasively by ventriculography as part of a cardiac catheterization procedure. A chest X-ray and an electrocardiogram are obtained to assist in the diagnosis. Laboratory studies usually performed during the initial workup include serum electrolytes, blood urea nitrogen, creatinine, thyroid-stimulating hormone, complete blood cell count, BNP, and routine urinalysis. The BNP level is a key diagnostic indicator of HF. High levels are a sign of high cardiac filling pressure and can aid in the diagnosis of HF. Cardiac stress testing or cardiac catheterization may be performed to determine whether coronary artery disease and cardiac ischemia are causing the HF.
Now let's talk about the medical management for heart failure.
Medical management. The overall goals of management of HF are to relieve patients' symptoms, to improve functional status and quality of life, and to extend survival. Medical management is based on the type, severity, and cause of HF. Specific objectives of medical management include the following: eliminate or reduce any etiologic contributory factors, such as uncontrolled hypertension or atrial fibrillation with a rapid ventricular response. Optimize pharmacologic and other therapeutic regimens. Reduce the workload on the heart by reducing preload and afterload. Promote a lifestyle conducive to cardiac health. Prevent episodes of acute decompensated HF. Treatment options vary according to the severity of the patient's condition and may include oral and IV medications, major lifestyle changes, supplemental oxygen, implantation of assistive devices, and surgical approaches, including cardiac transplantation. Managing the patient with HF includes providing comprehensive education and counseling to the patient and family.
Now, let's talk about pharmacologic therapy for heart failure. Several medications are routinely prescribed for systolic heart failure, including angiotensin-converting enzyme inhibitors, beta blockers, diuretics, and digitalis.
We are gonna discuss each medication, and let's start with angiotensin-converting enzyme inhibitors. Angiotensin-converting enzyme inhibitors play a pivotal role in the management of systolic HF. They have been found to relieve the signs and symptoms of HF and significantly decrease mortality and morbidity. Medications under angiotensin-converting enzyme are lisinopril, benazepril, captopril, enalapril or enalaprilat, fosinapril, moaxipril, perindopril, quinapril, ramipril, and trandelapril. Therapeutic effects: decrease BP and decrease afterload, relieves signs and symptoms of HF, prevents progression of HF. Key nursing considerations: observed for symptomatic hypotension, increased serum and cough, and worsening renal function. Next is angiotensin II receptor blockers. ARBs are prescribed as an alternative to ACE inhibitors, especially when patients cannot tolerate ACE inhibitors because of cough. Therapeutic effects includes decrease BP and decrease afterload. Relieves signs and symptoms of HF and prevents progression of HF. Medications: valsartan, candesartan, eprosartan, irbesartan, telmisartan, losartan. Key nursing considerations are observed for symptomatic hypotension, increased serum potassium, and worsening renal function. Hydralazine and isosorbide dinitrate. A combination of hydralazine and isosorbide dinitrate may be another alternative for patients who cannot take ACE inhibitors. Next is the beta blockers. Beta blockers are routinely prescribed in addition to ACE inhibitors, diuretics, and digitalis. The medication under beta adrenergic blocking agents are metoprolol, atenolol, and carvedilol. The therapeutic effect of beta blockers are dilates blood vessels and decreases afterload, decreases the signs and symptoms of HF, and improves exercise capacity. The key nursing considerations are to observe for decreased heart rate, symptomatic hypotension, and fatigue. Next is diuretics. Diuretics are prescribed to remove excess extracellular fluid by increasing the rate of urine produced in patients with signs and symptoms of fluid overload. The medication under diuretics are loop diuretic, furosemide, thiazide diuretic, metolazone, hydrochlorothiazide, aldosterone antagonist, spironolactone. Therapeutic effects of diuretics are decreased fluid volume overload and decreased signs and symptoms of HF. Key nursing considerations are observe for electrolyte abnormalities, dysfunction, renal dysfunction, diuretic resistance, and decreased BP. Carefully monitor input and output and daily weight. Next is digitalis. The most commonly prescribed form of digitalis for patients with HF is digoxin, lanoxin. Until recently, this medication was considered an essential agent for the treatment of HF, but with the advent of new medications, it may or may not be prescribed. Digoxin increases the force of myocardial contraction and slows conduction through the atrioventricular node. It improves contractility, increasing left ventricular output, which also enhances diuresis. Although the use of digitalis does not result in decreased mortality rates among patients with HF, it is effective in decreasing the symptoms of systolic HF and may help prevent hospitalization. Medication under digitalis is digoxin, lanoxin. Therapeutic effects of digitalis is, it improves contractility and decreases signs and symptoms of HF. Key nursing considerations are, observe for bradycardia and digitalis toxicity. Next is the calcium channel blockers. They work by slowing the movement of calcium into the cells of the heart and blood vessel walls, which makes it easier for the heart to pump and widens blood vessels. Medications are dihydropyridines, amlodipine, felodipine. The therapeutic effects are vasodilation and reduction of systemic vascular resistance. Key nursing considerations are observe for symptomatic hypotension, drowsiness, or dizziness. Medications for diastolic dysfunction. Patients with predominant diastolic HF may be treated with different medications than indicated for patients with systolic HF. After contributing causes such as hypertension and ischemic heart disease are evaluated and treated, patients may be started on beta blockers and other HF medications. An effort is made to restore normal sinus rhythm in patients with concomitant atrial fibrillation. Other medications for heart failure. Anticoagulants may be prescribed, especially if the patient has a history of atrial fibrillation or a thromboembolic event. Medications that manage hyperlipidemia are also routinely prescribed for the HF population. Nonsteroidal anti-inflammatory drugs such as ibuprofen should be avoided because they decrease renal perfusion, especially in the elderly. Then the nutritional therapy. A low-sodium diet and avoidance of drinking excessive amounts of fluid are usually recommended. And additional therapy may include supplemental oxygen. Oxygen therapy may become necessary as HF progresses. The need is based on the degree of pulmonary congestion and resulting hypoxia. Some patients require supplemental oxygen only during periods of activity.
Now let's talk about the nursing process.
First is the assessment. The nursing assessment for the patient with HF focuses on observing for effectiveness of therapy and for the patient's ability to understand and implement self-management strategies. Signs and symptoms of pulmonary and systemic fluid overload are recorded and reported immediately so that adjustments can be made in therapy. The nurse also explores the patient's emotional response to the diagnosis of HF because it is a chronic and often progressive condition. Part of the assessment is to include the health history of the patient. Nurses can ask about the signs and symptoms of HF, such as dyspnea, shortness of breath, fatigue, and edema. Assessment also includes the physical assessment of the patient, which is very important to know the cause of signs and symptoms and plan an effective and appropriate care for it. Next is the diagnosis. Here are some potential diagnosis that is based from the given assessment data: activity intolerance and fatigue related to decreased cardiac output, excess fluid volume related to the HF syndrome, anxiety related to breathlessness from inadequate oxygenation, powerlessness related to chronic illness and hospitalizations, ineffective therapeutic regimen management related to lack of knowledge. Next is the planning. Major goals for the patient may include promoting activity and reducing fatigue, relieving fluid overload symptoms, decreasing anxiety or increasing the patient's ability to manage anxiety, encouraging the patient to verbalize his or her ability to make decisions and influence outcomes, and teaching the patient about the self-care program. Now let's discuss the nursing interventions. In patient with HF, we nurses should promote the activity tolerance of our patients. Reduced physical activity caused by HF symptoms leads to physical deconditioning that worsens the patient's symptoms and exercise tolerance. Prolonged bed rest, which may be self-imposed, should be avoided because of its deconditioning effects and risks such as pressure ulcers, especially in edematous patients, venous thrombosis, and pulmonary embolism. A typical program for a patient with HF might include a daily walking regimen, with duration increased over a 6-week period. Safety guidelines to follow before taking the activities: begin with a few minutes of warm-up activities. Avoid performing physical activities outside in extreme hot, cold, or humid weather. Ensure that you are able to talk during the physical activity. If you cannot do so, decrease the intensity of activity. Wait 2 hours after eating a meal before performing the physical activity. Stop the activity if severe shortness of breath, pain, or dizziness develops. End with cool-down activities and a cool-down period. Patient with HF can also receive IV diuretic therapy. The patient's fluid status is monitored closely, auscultating the lungs, monitoring daily body weight, and assisting the patient to adhere to a low-sodium diet by reading food labels and avoiding high-sodium foods such as canned, processed, and convenience foods. The patient is also taught about the correct position or taught how to assume a position that facilitates breathing. Planning of care for patient with HF also includes teaching the patient how to control his or her anxiety. Because patients with HF have difficulty maintaining adequate oxygenation, they are likely to be restless and anxious and feel overwhelmed by breathlessness. These symptoms tend to intensify at night and may interfere with sleep. Emotional stress stimulates the sympathetic nervous system, which causes vasoconstriction, elevated arterial pressure, and increased heart rate. This sympathetic response increases the cardiac workload. By decreasing anxiety, the cardiac workload is also decreased. Monitor and manage potential complications and promote home and community-based care. Teaching patients self-care. The nurse provides patient education and involves the patient in the therapeutic regimen to promote understanding and adherence to the plan. When the patient recognizes that the diagnosis of HF can be successfully managed with lifestyle changes and medications, recurrences of acute HF lessen, unnecessary hospitalizations decrease, and life expectancy increases. Continuing care. Success in management of HF requires a complex medical regimen and multiple lifestyle changes. Assistance may be provided through home health care, an HF clinic, or telehealth management. Depending on the patient's physical status and the availability of family assistance, a home care referral may be indicated for a patient who has been hospitalized. End-of-life considerations. Because HF is a chronic and often progressive condition, patients and families need consider issues related to the end of life. Although the prognosis in HF patients may be uncertain, issues often arise sooner or later related to the patient's thoughts and possible concerns about the use of complex treatment options. Last is the evaluation. Here are some expected desired outcomes for the patient. First, demonstrates tolerance for increased activity. Describe adaptive methods for usual activities. Schedules activities to conserve energy and reduce fatigue and dyspnea. Maintains heart rate, blood pressure, respiratory rate, and pulse oximetry within the targeted range. Second, maintains fluid balance. Exhibits decreased peripheral and sacral edema. Demonstrates methods for preventing edema. Third, is less anxious. Avoids situations that produce stress. Sleeps comfortably at night. Reports decreased stress and anxiety. Denies symptoms of depression. Fourth, makes sound decisions regarding care and treatment. Demonstrates ability to influence outcomes. And lastly, adheres to self-care regimen. Performs and records daily weight. Ensures dietary intake includes no more than 2 to 3 grams of sodium per day. Takes medications as prescribed. Reports any unusual symptoms or side effects.
That's the end, and thank you for watching.